myself, Dr. Rakesh Shakya, coming from the very small place, Chitrakoot. Actually, in the previous lecture, the subluxated cataract nicely covered. So I am going to the same technique in the very simple cases, not very complex cases. So as you know, that jonular compromise, the following trauma, surgery, and pseudo exfoliation or systemic condition complicate the every step of the cataract surgery and pose the serious challenge in terms of safety and visual outcome. Depending upon the degree of the subluxation, the surgical procedure is chosen. Their capsule bag can be successfully preserved with the help of the capsular hooks. So newer technology including capsular tension rings, capsular fixation hooks, and have the greatly improved the ability to remove these subluxated cataract through the anterior approach. Additionally, advanced and parameters in the new phacoemulsification unit also allow the safe removal of the subluxated cataract. So the three crucial steps of the cataract surgery can be defined: position of the self-sealing corneal incision, well-centered and intact capsular axis, and lens cracking and emulsification, also valuable in the complicated cases. So I am going to just a small video. Please give the volume, please.
First, beginners must know about the anatomy of the jonular fiber that originate from the basal lamina of non-pigment epithelium of ciliary body and insert into the lens capsule at the equator region. These fibers play an important role in the lens stability. Its weakness results in alteration of the lens stability. Jonular dialysis may be pre-existing and brought into existence by the operating surgeon. Jonular compromise complicates every step of cataract surgery. Beginner faced serious challenges in terms of safety and visual outcome. The detection of the jonular dialysis at the earliest remains the crucial point which determines the subsequent management and final outcome of the surgery. I am going to demonstrate to manage various degree of jonular dialysis with the use of CTR in very simple two-Sinskey hook technique. CTR has two holes at each end. One end is inserted from the side port, so this leading end has to be engaged underneath the anterior capsule rim and gradually push the CTR with the help of McPherson forceps. So I take help of the both hands. Now when I have reached the trailing end, I take Sinskey hook in my left hand and goes through the left side port. Then insert the trailing end with the help of another Sinskey hook in my right hand. At this time, the left hand Sinskey hook always behind the CTR, and you can see how two Sinskey hook guide the CTR. Sometimes during the insertion of the CTR, trailing edge get released in the angle and become difficult to retrieve. In the process of retrieving of the CTR, it can cause iris trauma, bleeding, and DM detachment. This was a 75-year-old female, had hypermature cataract with jonular dialysis more than 4 clock hours. A temporal clear corneal phaco with foldable intraocular lens implantation was planned for this patient. Anterior lens capsule stand by the minimal use of trypan blue to improve the visibility of the rhexis margin. 5.5 mm rhexis was fashioned, which is desirable size for the hard cataract. Hydrodissection not required. In this case, the capsular bag was stabilized by two capsular hooks placed in the area of the jonular dialysis, and phacoemulsification was done. So in this, I implanted CTR with the help of injector. I was noticed small PCR during IA without vitreous disturbance. So I implanted intraocular lens in the bag. Post-operative lens was centered with BCBA 6Y9. This was a case of traumatic subluxation, more than 6 clock hour. I have planned clear corneal phaco with Sioni ring. Capsular access may be challenging due to absence of counter traction. After initial capsule tear with cystitome, I always apply shearing force with atrata forceps toward the intact zone to make circular access. Gentle hydrodissection done at multiple sites. Now capsular bag was stabilized by 3 capsular hook placed in the area of zonular dialysis. After that, rotation of the lens became very easy and phaco-multiplication was done by modified stop and chop technique. After conjunctival peritomy, a small scleral groove made 3 mm away from the limbus. Sioni ring now used. This ring has additional suturing eyelet for scleral fixation. A 10-0 Prolene double arm suture is passed through the eyelet for the scleral fixation. And Sioni ring is introduced through the side port or main port and implanted into capsular bag with the help of McPherson and Sinskey hook. Ensure first eyelet goes into the capsular bag and rest of the ring gently dialed. Then 26 gauge needle is passed through the scleral bed about 2 mm away from the limbus. Prolene suture needle adopting into it at the pupillary center. Then needle with suture brought out through the scleral bed. Similarly, another needle with suture also brought out in the same way but placed 1 mm away from the first site. Ends of the Prolene suture now tied together and secure the ring with the sclera by 7-8 knots. Now Sioni ring and capsular bag well centered. Intraocular lens implantation was done. Surgery in the presence of zonular dialysis can be challenging situation for even the most experienced surgeon. So everyone should follow the following guidelines to get better results.
That was a very
Thank you
nice
so
talk,
much.
Dr. Rakesh, where you have shown all the principles of dealing with subluxations, very explicit.